remember to keep up to date with our content by joining the S. Slack, joining the S. Faces page, as well as liking and subscribing to the Medics.Academy YouTube channel. So, I'd like to introduce Myron, who will be giving you an overview of hearing loss as well as some of the tests associated with hearing loss.
So, hi everyone. My name's Maren Garden. Thank you for listening to this. So today I'm going to be speaking to you about hearing loss. I'm going to do it in 3 parts. So this is the first part of hearing loss. Make sure that you check out part 2 and 3 of this video, which you can find in the description to this video link. If you'd like to see any of my colleagues' lectures that they're producing, do click on other videos on this channel as well for you to see. Please like and subscribe to the Medics.Academy YouTube channel to get notified about any future videos, because our content is consistently updated for you. And if you're a medical student, please sign up to the free SDocs program, which you can do from a link in the description of this video, again, just to keep updated. Right, so I'll begin. Today I'm going to go over types of hearing loss, history and examination for a patient presenting to you with hearing loss, and that's going to be in part 1 of the video. In part 2, I'm going to go over causes of hearing loss, and then in part 3, I'm going to go over audiograms. The reason we've decided this topic is because hearing loss is something that can be caused by a range of different things, and often can cause a lot of confusion, especially about the examination with the Rinne's and Weber's tests and also audiograms. They can often look quite ominous in an exam setting, but actually aren't too bad at all. So hopefully I'm going to clear those up for you today. So part 1. So this is just a brief anatomy of the ear. We're not going to go into too much detail about it today. But so you've got the outer ear, and the middle ear. The middle ear is consisted of the middle ear bone. So you've got the malleus, incus and stapes, and that's important slightly later on. If you've got a problem with the outer ear or the middle ear, it will cause a conductive hearing loss. Whereas if you get a problem with the inner ear, so the cochlear nerve, the vestibular nerve or the cochlea, it will cause something called a sensory neural hearing loss. So that's just said here more clearly. So a conductive hearing loss is when sound is unable to transfer between any point from the outer ear, the external auditory canal, tympanic membrane, and the middle ear. Whereas sensory neural, as I said, is a dysfunction of the cochlea or vestibular cochlear nerve. This is quite important because you can differentiate what causes them, which we'll go through later on in part 2 of the video, by how they present. So if a patient comes to you with presenting of hearing loss, you go over your normal history that you'd take with any patient. So start with the history of presenting complaint. So discuss the onset of their hearing loss. Some might have a very sudden onset, whereas some is more gradual. For example, old age hearing loss is more gradual, whereas sudden onset sensory neural hearing loss is quite sudden. Patients might have other symptoms which might give away the diagnosis. They might have otalgia, so earache, any discharge, whether they're having any vertigo, so rotatory dizziness, or tinnitus. Also whether there's any associated headache with them. And on discussion with the patient, try and assess whether they've had any previous trauma or noise exposure that they can think about that may have contributed to their hearing loss. Discuss past medical history. So some of these patients may have Down syndrome or other craniofacial disorders, which can affect the anatomy of the ear canal, which can cause some of these problems. Patients might have had recurrent ear infections in the past. All of these may contribute to a cause of hearing loss. It's important to ask about drug history. So there are certain drugs which are ototoxic, systemic aminoglycosides, so the antibiotic aminoglycosides, and cytotoxic agents, both can cause permanent hearing loss. Salicylates and quinine can also cause hearing loss, but these are reversible once you stop the drug. Important to ask about family history, as some of these will run within the family, or more likely to occur if a first-degree relative has had it. And finally, go over social history. So similar to what I said above, any occupational hobbies that might cause hearing loss. So this could be something like someone working in a factory and dealing with loud machines, or even listening to loud music constantly. So onto the examination. So to start off with, you do otoscopy. So otoscopy, as you can see here, is an exam you would do to look at the outer and middle ear. This picture on the right is a patient with otitis media with effusion, and they've got a grommet inserted. So this is really helpful to give you a better picture of the outer and middle ear, allowing you to diagnose things that might be causing a conductive hearing loss. And then you'd go on to do free field hearing. So free field hearing is quite crude, but good to do. So the way you do it is you would mask the ear that is not being tested by rubbing the fingers in front of the ear. So you kind of go like this to create a masking sound in front of the ear that you're not testing. You would position yourself 60 centimeters away from the patient's ear and whisper a number or word that you've pre-agreed with into their ear. So you would stand this side of the patient while doing this in the other ear. If there's no response when you say your number or word in a normal voice, this suggests that the hearing level is 48 decibels or worse. If you say it in a loud voice, this suggests that it's 76 decibels or worse, which we'll come on to later about how severe that is. But yeah, and if they can't hear you at your loud voice, you then need to come closer and come to about 15 centimeters. And this will allow you to test lower decibels. And finally, you go on to your tuning fork test. So tuning fork tests are often cause quite a lot of stress and confusion between medical students. It took me a long time to understand it myself. But actually, once you know it, it's really easy to then make sense of it. Often it can be done within MCQs. They can give you a scenario, so it's useful to be able to understand them. What's really important with your tuning fork test, that when you start the examination, you say that you're using a 512 Hertz tuning fork. Just really important to remember because they can often ask you these questions. So you start off with Weber's test. So with Weber's test, as you can see in this diagram that I've created here, you put the tuning fork on the top of the forehead. If their hearing is normal, what you will find is that the sound is equal in both ears. If it's abnormal, the sound will localize to one ear rather than the other. If it's sensory neural hearing loss, so a problem with the inner ear, so the nerve or the cochlea, the sound will appear louder in the normal ear. Whereas if it's conductive, so a problem with the outer or middle ear, the sound will be louder in the affected ear. Although you do Weber's first, the problem is that you don't know whether you have sensory neural or conductive hearing loss yet. So you then need to move on to do Rinne's. So with Rinne's test, you start by placing the vibrating tuning fork on the mastoid process, so behind the pinna. And the way you can remember that this is what Rinne's is the saying Rinne under the pinny. So you put the tuning fork under the pinna. You press it firmly on the mastoid process, and this will be testing the bone conduction. When if the patient tells you that they can hear the sound, you ask them to tell you when they can no longer hear it. And you would then move it to in front of the ear to test air conduction. What's normal is air conduction should be better than bone conduction. And that's normal, but that is also the case in sensory neural hearing loss, because there is nothing wrong with the outer and middle ear in sensory neural hearing loss. So there'll be no impact to the air conduction, if that makes sense. However, in conductive hearing loss, because there's that problem in the outer and middle ear, air conduction will not be as good as bone conduction. And therefore, when you move the tuning fork to in front of their ear, the patient won't be able to hear a sound. So you've now done Webers and Rinneys, and you then need to put all of this information together to work out what situation you've got. So I've created a table for you here just to really go over it again. So if a patient has normal hearing, in Webers, it will be non-lateralizing, so it will sound the same in both ears. You wouldn't really then need to do Rinneys, but if you then do the Rinneys test, it would be Rinne positive, and air conduction would be better than bone conduction. So when you move the tuning fork from the mastoid to in front of the ear, they'd be able to hear it. Sensory neural hearing loss will also have a positive Rinneys test and will lateralize to the normal ear. So this means that, it will lateralize to the normal ear. I'll go over a case just to, again, go over this again. Conductive hearing loss will have a negative Rinneys test, so they won't be able to hear it when you move it in front of the ear. And you then go back and it'll be lateralized to the affected ear. So a quick case for you. A patient comes to you with hearing loss. You do a Webers test and it localizes to the right ear. Because of this, you then go on to do the Rinneys test. When the patient is able to hear the fork when it's moved from the mastoid to the air position in both ears. So what kind of hearing loss do you think this person has? So this person has left sensory neural hearing loss. So I'm just going to go over this one more time just to really drill it in and make sense. So the fact that when you move the tuning fork from the mastoid process to the air position, the patient can hear it, and when you do it on both ears, this suggests that it's sensory neural hearing loss, because air conduction is better than bone conduction. Because it localizes to the right ear, as I showed in this table, in sensory neural hearing loss, it lateralizes to the normal ear. This means that the ear that you hear it loudest in will be normal. So it's therefore left sensory neural hearing loss, the problems within the left ear. Brilliant. So that's the end of part one, just going over mainly the examination and Webers and Rinneys. Be sure to check out part two, where I'll go over the different causes of hearing loss. Thank you.
That was fantastic, Myron. Thank you so much. Now Myron will be going on to causes of hearing loss in the next video.
Hi everyone, welcome to part two of discussing hearing loss. So in this part of the video, I'm going to be going over the different causes of hearing loss. So if you'd like to listen to part one, where I went over the history and examination that needs to be done for hearing loss, or part three, where I'll be going over audiograms to investigate hearing loss, please do check those out. The links will be in the description of this video below. Also, my colleagues have been doing a variety of different videos, so do click on other videos on this channel. If you'd like to subscribe to Medics.Academy YouTube page, that would be great, and you can get notified of any future videos because we're constantly updating our content. And finally, if you're a medical student and you want to sign up for the free SDocs program, you can do it from the link in the description to this video. So I'll commence. So there are 3 different parts of the ear, like I said in video 1. So you've got your outer ear, your middle ear, and your inner ear. Your outer and your middle ear causes conductive hearing loss because the sound cannot get through either the external auditory canal or your tympanic membrane. And there are a variety of causes that you can look at, which we're going to go over in a bit more detail. With the inner ear, it causes sensory neural hearing loss because of impact to either the cochlea or the vestibulocochlear nerve. So going over the outer ear causes, impacted earwax. So this is one of the most common reasons for people having altered hearing loss, and the main reason for it is the use of cotton buds. So earwax should be found in the lateral 1/3 of the ear canal, and if it's found more medially to this, it suggests that cotton buds are being used and it's impacting the earwax. Other causes can be structural abnormalities, so craniofacial disorders such as Down syndrome. The elderly and people with recurrent infections are also more likely to get impacted earwax. These patients are likely to come with you with a fullness, earache, and itching. They might also have tinnitus and vertigo, but one of the main things, if they're coming to you, is probably because of their hearing loss. This can be quite easily treated. Sodium bicarbonate or oil drops can be used. You've got to make sure that you explain to the patients how to use these properly. They need to be lying down on their side to ensure that the eardrops can fully get in, and they need to stay down there for a little while to make sure that they don't just fall out again. Ear syringing can be done. This can be done by the GPs, but actually earwax is one of the most common GP referrals to ENT and one of the most unnecessary referrals to ENT, but GPs tend to not overly like ear syringing. You can also do direct visual removal, which will be done by an ENT consultant. And moving on to otitis externa. So otitis externa is inflammation of the external ear canal. It's caused mainly by bacteria, so Pseudomonas or Staph aureus, but it can also be fungal. So if it's fungal, it's most likely to be Candida or Aspergillus, but this isn't very common. It can also be non-infectious. Skin conditions can predispose to this, so eczema, acne, or dermatitis, but also allergies and irritants might cause otitis externa. Risk factors for it kind of linked with some of the causes, but a humid climate or swimming. Otitis externa might also be called swimmer's ear because it is quite prevalent in the swimming population. Elderly, anatomical variant, so again, patients with Down syndrome are more at risk of this. Any past medical history of surgery or radiotherapy to the ear, and also immunosuppression. With immunosuppression, this is quite important because patients with diabetes or who are immunosuppressed are actually more likely to get the complications of otitis externa, which can be much more dangerous. Patients usually present with quite severe ear pain. There might be discharge or itching, and the ear is usually quite red. So this is something that you would see in the otoscopy and often quite obvious. They'll also be feeling, if they've got an infection as well, they'll also have a fever and be feeling generally unwell. And again, this can lead to hearing loss. Hearing loss isn't always the first thing that they'll present with. It might be something that comes slightly later on. For these patients, conservatively, sorry, Conservatively, you need to make sure that they're careful with water precautions. So they shouldn't be getting their ear wet. So they should avoid swimming and getting water into their ear canal. So when they're in the shower or having a bath, they need to be cautious of this. Treatment is antibiotic and steroid drops. You need aminoglycosides or quinolone. If otitis externa is very bad, you might need to do microsuction. And this is important because within the debris, there'll be lots of bacteria. So you need to clean this debris to decrease the bacterial load to allow the antibiotics to work. Sorry. You can also use an otowick. So an otowick allows you to put antibiotics through the debris to ensure that they work better. Complications of otitis externa include malignant otitis externa. So this is an ENT emergency and patients need to be admitted. They will be given a high dose of antibiotics for a longer period of time to ensure resolution. But it's more risky here because you risk damage to the facial nerve and also for intracranial progression, so infections of the brain. So it's really quite important. These patients might also get pinna or periauricular cellulitis. Cellulitis will affect the whole ear, including the earlobe, which is quite important to remember. And again, these patients will just need to be given some antibiotics. Now going on to ear canal stenosis. So I'm not going to spend very much time on this because it's quite rare, but ear canal stenosis can be caused by recurrent infections, any trauma to the ear, which can damage the ear and cause strictures and scarring, tumours, any inflammation to the ear, and also radiotherapy. Now going on to middle ear conditions. So again, both outer and middle ear will cause your conductive hearing loss. So otosclerosis. So you've got your three middle ear bones, your ossicles, and one of them is the stapes. Otosclerosis is when there's abnormal bone formation around the stapes. The cause is unknown, but there's thought to be a familial link. You're more likely if a first degree relative has it. And yeah, so there's thought to be some family history, but it's not completely understood. These patients present with a bilateral, which is quite helpful to differentiate it, conductive hearing loss. In the audiograms, which I'll be going over in part 3, it's also important to note that they'll have a dip in the bone conduction at 2000 Hertz, but I'll come on to explain this later, so don't worry. These patients might also present with tinnitus and dizziness. Often it's a triad of symptoms that they present with. Often you don't give these patients any treatment apart from maybe hearing aids to improve their hearing. If it severely impacts their quality of life, you can do a stepidotomy where you remove some of the bone around the stapes, but it's not always needed. Then going on to otitis media. So this is inflammation of the medial ear. So it's most common after an upper respiratory tract infection in young children. And therefore the cause tends to be either strep pneumonia or Haemophilus influenza. Risk factors for this include nursery, upper respiratory tract infection, like I've just said, if they're of a poor socioeconomic status, if they use a dummy, and craniofacial syndrome, so Down syndrome or Turner's. As I said, this most typically occurs in children, and they typically present with pain and being generally unwell. Unlike otitis externa, there should be no discharge unless it's a complicated otitis media, and they'll also get conductive hearing loss. In an uncomplicated presentation of otitis media, antibiotics should be delayed. Otitis media is one of the most common reasons for inappropriate antibiotics. And as we know, with antibiotic stewardship, it's really important that we reduce antibiotic prescriptions. So you should wait 48 hours to prescribe antibiotics unless the child is below 2 years of age, and then it is suggested that you give antibiotics. If it doesn't clear up within 48 hours, it's then suggested that you give them 5 to 7 days of amoxiclav. If the patient has recurrent infections, so more than 5 infections in 6 months, they might need grommet insertion. So this is just to allow for, to prevent the buildup of pressure and allow for ventilation of the eustachian tube. There are quite a few complications of otitis media. Most commonly, otitis media with effusion, cholesteatoma, and perforations. I'll just go over them very briefly, especially glue ear and perforations, because these both cause hearing loss as well. And actually, otitis media might be quite mild initially in patients, but if they've got glue ear, it's more common. So glue ear is just a chronic condition. So it's chronic otitis media, and it's caused by infection on top of poor eustachian tube functioning. What you risk with these patients is that with their young age and their hearing problems because of otitis media, they end up with poor speech development and can be quite clumsy and behavioural issues. So often these children might be dealt with for psychiatry reasons instead, or behavioural problems and parents not quite understanding, but actually it's because of their hearing loss. Cases can resolve in about 3 months, and hearing aids can be used until this time. But if there's no improvement, again, grommets need to be inserted for these patients. Perforation can occur from otitis media due to the buildup of pressure by the tympanic membrane. Perforations can heal themselves, and so they most don't need to be treated, especially when they're small. If they are big, then they will need to be managed. So now going on to inner ear causes of hearing loss. So just to repeat myself again, inner ear problems will cause sensory neural hearing loss. So it's a problem to the cochlea or the vestibular cochlear nerve. So the most common cause of sensory neural hearing loss is age-related hearing loss. So this will occur in most old people. It tends to be quite gradual and develops over time as they age. They most often perceive it when it begins to affect their speech. So presbycusis affects high frequency hearing loss, which we'll come on to explain slightly further in the audiogram section. But the problem with losing high frequency sounds is that this is where most of the consonants are heard, and therefore it can affect their speech. It also is really difficult for these patients to hear in quite loud, noisy environments, which often means that they're quite withdrawn. You can't really manage these patients apart from with hearing aids, but hearing aids are really important to allow them to hear better. Then going on to noise-induced hearing loss. So this is quite self-explanatory. It can be caused by either a sudden, really loud noise or prolonged exposure. So through occupation, working with loud machinery, things like that. Again, you get high frequency hearing loss. And these patients often also present with tinnitus and a woolly ear feeling, so a woolliness of their ears. Again, with these patients, you just need to manage them with hearing aids because there's nothing you can really do. Going on to Meniere's disease. So this Meniere's is something that you might know about from learning about vertigo. Meniere's is one of the most common causes of vertigo. And you've got a lot of different causes of vertigo, which can be sometimes quite difficult to differentiate, but Meniere's can also cause hearing loss. So Meniere's is when there's a change in the fluid volume or endolymph in the labyrinth. It's most common in women between 35 to 40 years of age, and they'll present with fluctuating and episodic vertigo between 20 minutes to 6 hours. The hearing loss tends to accompany the vertigo, so it will accompany the episodes of vertigo. And when the vertigo improves, the hearing loss will also improve. These patients might also have nystagmus, and they might also have tinnitus. The tinnitus may go on for longer than the episodic periods of vertigo. So it's slightly different from the hearing loss and vertigo. And they also sometimes complain of this sensation of fullness in their ears. In order to manage these patients, you can do supportive treatment. So there's something called vestibular rehab to try and help improve their symptoms. Hearing aids might help with their hearing loss. Also, through a low salt and caffeine diet and regular exercise has also been shown to be really effective in helping to treat these conditions. Beta histines and diuretics can be used for these patients. The diuretic that you want to use is bendroflumethiazide. And with acute attacks, you can give them vestibular sedatives, but as with all sedatives, you shouldn't be giving them in the long term, and they should only be used in the acute attacks. There's also a large number of surgical treatments that you can do for Meniere's disease, including grommet insertion, something called endolymphatic sac decompression, or a vestibular nerve section. These often aren't used, but if it's severe, then they might be. Acoustic neuroma or a vestibular schwannoma is one of those things that is quite often asked about in MCQs. Obviously, it's a tumour, so it is something to be concerned about. However, what a lot of people don't appreciate with acoustic neuroma is that it's a very, very slow-growing tumour. Because of this, and the slow-growing nature, often these patients will present with quite progressive, slow, gradual loss of hearing. And then also present with tinnitus and balance problems. It tends to be unilateral, and a kind of buzzword to anyone with unilateral progressive hearing loss. You need sensory neural hearing loss, you need to think about acoustic neuroma. To complicate it slightly, if these patients have the neurofibromatosis 1 gene, this will actually increase their risk of acoustic neuroma, but it's more likely to be bilateral hearing loss. So that just complicates it ever so slightly. Because of the slow-growing nature of these tumours, a lot of them are observed to begin with until there's severe hearing loss or other symptoms become difficult, or you're worried about it spreading further. When the tumours of a certain size, most commonly they'll treat it by surgery, but radiotherapy is also beginning to be used more and more. And then our final cause of hearing loss is sudden idiopathic sensory neural hearing loss. So with conductive hearing loss, you should always be able to find a cause for the hearing loss. However, with sensory neural hearing loss, sometimes there is a cause that can't be found. To diagnose sudden idiopathic sensory neural hearing loss, they need to have a loss of more or equal to 30 decibels in 3 contiguous pure tone frequencies, so in your audiograms, over 3 days. These patients will present with sudden or rapidly progressive unilateral sensory neural hearing loss. If it's not treated in a timely manner, this can become permanent hearing loss. However, if given oral prednisolone as soon as possible, the outcomes have been shown to be quite effective. It's something that GPs often don't like prescribing for and often refer to ENT, but giving oral prednisolone has massively shown to improve the prognostic factors. Other negative prognostic factors are if the patient is younger than 15 or over 65, if they have an increased ESR, if they present with vertigo, if they do present with bilateral, so bilateral is quite a rare presentation, or if when they present they have severe hearing loss. It's quite difficult to treat these patients after the initial bit, and often if it's not treated properly to begin with, it's likely to continue. Some do spontaneously resolve. Yeah. Okay, so that's the end of part 2. Please do check out part 3, where I'll be going over some audiograms, another thing that a lot of medical students find very scary, but really aren't that bad.
That was great, Myron. I think that was perfect for anyone who wanted to learn more about hearing loss for their next exams. Now we'll be going to audiograms. So
hi everyone, this is the final part of my talk on hearing loss, and we're now going to go over audiograms, or pure tone audiograms. So this is something that I definitely know when I first looked at, I found quite intimidating and didn't really understand. So I'm hoping in this session I'll just be able to break it down really simple, and so that you'll be able to tackle it if it comes up in an MCQ or an OSCE or anything like that. So this is a normal pure tone audiogram result. A pure tone audiogram is the most common method for assessing hearing. It's non-invasive, and it will be done by placing the patient in a soundproof box where they'll have headphones on. The patient and examiner will be in contact through a microphone and a headset. And what will happen is they'll be given different sounds to listen to, and they'll have to press or raise their hand to the examiner to acknowledge that they can hear them. These results will then be put on this graph. If there's shown to be an abnormality in hearing, what they'll also do is bone conduction. So there'll be an instrument on the head that causes vibrations through the skull to stimulate the cochlea, and this will test bone conduction. And I'll explain why this is important in a little bit. So as I said, this is normal, but I'm just going to go over in more detail about how you read it and what's what to understand why it's normal. So I've created here, so along the left-hand side, if you can see my arrow, is the hearing level in decibels. So this is the intensity of their hearing. And along here is frequencies. So this is what frequencies they can hear. So this is quite important because, as explained in part 2, some causes of hearing loss will occur, or more commonly occur, at lower or higher frequencies. And this is important for another reason, because vowels tend to be heard at the lower frequencies, whereas consonants are heard at high frequencies. And this really makes a difference to patients' speech or understanding and what they can hear. The different things that can be put on a pure tone audiogram are sometimes a bit confusing. An X will be used for left air conduction. So this is the noise that they hear through the headphones, whereas an O is used for right air conduction. In some audiograms, the right ear will be red and the left will be blue, but this isn't in all of them. So I've used black here, but that can sometimes happen. What you'll then do is bone conduction, like I said. Unmasked bone conduction means that there will be no sound through the alternate ear. for example, if you're testing the right ear, if you're testing right bone conduction, there'll be no sound through the left ear. The problem with this is that there might be some bias, whereas if you put noise through the opposite ear, you'll get masked bone conduction, and this is more reliable. So this is what's often done, and you'll often see the masked bone conduction signs. These little brackets confused me, but actually make quite a lot of sense when you look at them. A left masked bone conduction, the left, with right masked, the bracket faces to the right. Off the scale might mean that the patient hasn't heard anything, or that the reading is too low to assess. So, as I said again, this is a normal audiogram. So, the X's here show the left ear, and the O's here show the right ear. Hearing should be between 0 to 20 decibels. And if it's within this range, it's normal. It then progresses and gets worse and worse as you go down. So 20 to 40 will be mild hearing loss, 40 to 70 is moderate, 70 to 90 is severe, and over 90 is profound. Someone with normal hearing in their history should be able to understand speech in most normal environments, and no amplification is needed. Someone with mild hearing loss it's usually their family who notice something before they do. They might struggle in noisy environments and sometimes turn the TV up louder, but it doesn't really affect them too much. Moderate hearing loss, people begin to miss what people are saying, and they'll begin to notice it themselves, that they're struggling to hear. Severe hearing loss, you often get patients who are quite frustrated, and they find hearing difficult in most situations. If they have profound hearing loss, they'll have major problems with most communication, and sometimes visual aids are needed for these patients. So going over some examples for you now. So in this case, if you can see that the left ear is normal, so your hearing is, your air conduction is between 0 and 20, and so is your bone conduction. Your right ear, however, has low frequency hearing loss. So in these low frequencies, between about 250 to 2000, you've got mild hearing loss. In order to understand whether a patient has conductive or sensory neural hearing loss, you need to look at the difference between the air bone conduction. So as I was explaining in part 1 of this video, conductive hearing loss, they'll have bone conduction will be better than air conduction because they've got a problem with their outer or their middle ear. So this means that their bone conduction should be normal because there's no problem with the inner ear. And this is how you differentiate. So this will be conductive because there is a difference between your bone and air conduction. This audiogram here would likely be caused by something such as otitis media. It's low frequency, mild hearing loss, and it's conductive. Sorry, didn't mean to sit there. It could also be caused by something like otitis externa. To differentiate between these two, you need to go back to your history and your examination. So looking at whether the patient has discharge, whether they've got erythema of the ear will be really important here. Next case. So here, because you've got matched bone and air conduction, as you can see that the bone and air conduction follow each other, it suggests that it's sensory neural. Unlike the other one, this one is bilateral, and the hearing loss is actually at the higher frequencies. So between about 1,000 to 8,000, they've lost their hearing in this case. So if we think back to part 2 and what might cause this, bilateral high frequency, moderate sensory neural hearing loss, one of the most common causes will be presbycusis, so old age, and what happens in old age. Another cause of this is ototoxic drugs. So again, like I mentioned in part 1, the most common ototoxic drugs, so drugs that damage the ear, are either aminoglycosides or cytotoxic agents, so any chemotherapy. Going on to the third case. So here we have, despite this one looks slightly confusing because although there's quite a big gap between the bone and the air conduction, which might make you think conductive, actually bone conduction is still abnormal, which means again is sensory neural hearing loss. It's only in one ear, and it's in the right ear, and it's found at all frequencies, so there's not a range in the frequencies it's found at. This is most likely to be acoustic neuroma or idiopathic sensory neural hearing loss. Both of these might present with, are likely to present with more gradual hearing, skip that. Acoustic neuroma is more likely to present with more gradual hearing loss, where over time they develop quite severe, profound hearing loss, whereas idiopathic sensory neural hearing loss is more likely to be sudden onset or rapidly worsening. So this is quite useful how to differentiate between these two. Going on to the next case. So this one, the bone conduction, as you can see here, is normal. So within the 0 to 20 range. However, the air conduction in the right ear is abnormal. So this will be a conductive hearing loss. Because the hearing loss here is between about 40 and 50 decibels, this suggests that it's moderate hearing loss. It's only unilateral, which is important to note. And something here that is quite subtle but useful to notice is that there's a peak decrease in bone conduction at 2000 Hertz. So this is something called the Carhart notch, and is quite indicative of otosclerosis. So it's something that's important to just try and remember for any MCQ questions that come up. The Carhart notch at 2000 Hertz for bone conduction. So even though it's relatively normal, they'll still have this dip at this level. And this is indicative of otosclerosis, so damage to the stapes bone, like I was explaining in part 2. So we've now got, if you look at this photo, it's bilateral, so it's the same in both ears. The air and bone conduction are matched, so it suggests that it's sensory neural hearing loss. Both the air and bone conduction are abnormal. And what you get, if you look in both pictures, is that there's quite an obvious dip at about 4000 Hertz. This is indicative of noise-induced hearing loss. So often noise-induced hearing loss is bilateral, and they'll have this dip. Again, another thing that's just really useful to remember, because it might come up and it's quite easy to be examined on. So that's the end of my audiogram bits. They can be quite confusing, but just looking over them and really understanding the key and what everything's explaining, and just going through them in a very logical manner, looking at whether there's a difference between the left and the right ear, then looking to see whether there's a difference between the air and the bone conduction to decide whether it's conductive or sensory neural, looking at also looking at whether it's mild, moderate or severe, all these things that if you just go over step by step, it becomes much more easy to read. So thank you very much for listening. If you've got any questions, please just feel free to email me. Thank you so much for listening.
Now that you've learned all about hearing loss, Josh can give you an introduction into global health ophthalmology. And remember to keep up to date with our content by joining the S.Slack, join the S.Spaces page, and like and subscribe to the Medics.Academy YouTube channel.
Hello all, my name is Josh. I am a final year medical student at the University of Southampton, and this is part one of my Introduction to Global Health Ophthalmology series webinar, as done with the Medics.Academy virtual elective May cohort. I've done the Medics.Academy virtual elective with loads of different medical students who will also be posting their webinars as well. So do keep an eye out for them and on the Medics.Academy YouTube channel. But we shall start on and go ahead with part one, Introduction to Global Health of Ophthalmology webinar. This is an outline of my webinar series. So I will start with an introduction now, and then I will do part one, which is going to be the importance of global health ophthalmology. Look out for my next videos, which will be part two, 3 causes of avoidable blindness, and part 3, a case study interview with Selfless UK charity. So really interesting things that we're going to be looking at and talking about. And an introduction to myself. I am a final year medical student at the University of Southampton, have an interest in ophthalmology, medical education and research. And particularly, I guess the interest in ophthalmology and medical education is why I've culminated together and done this webinar. And why this topic? I found it interesting. It's something that I've looked at before, not something that's traditionally in the medical school curriculum, but I think it's a really important topic to know about. Not just the concepts that you learn from a medical perspective, but also from a global perspective, global health, socioeconomic development, all types of really just interesting knowledge that's important to know. I put an asterisk because even though it's not in a medical school curriculum, it does come up on the Duke Elder exam. For anyone who's interested in that exam, it is search up more on it if you don't know what it is and you are interested in it. But it's just an exam that you can opt in to do as a medical student. It's all based on ophthalmology. If you do well on the exam, it will help your CV basically. So that's the Duke Elder exam. And now we'll go on to fully part one, the importance of global health ophthalmology. So as we start, I would like you all to think about how blindness can affect someone's life. Past the point that, of course, someone who's blind can't see, how else is that going to affect their life and the things that that individual can do? So just have a think about that for 10, 15 seconds. Right, so I think that's been about 10, 15 seconds. And in answer to this question, these are some of the consequences that I've thought of or that are common in literature on this subject. And there's so many. You can see it's really, really widespread in the devastation that's being blind or heavily visually impaired can cause. Economical consequences, social consequences, psychological or psychiatric consequences. They may have lost their independence with the activities of daily living. Can really severely affect education if you're blind or visually impaired as a child. It's going to increase your comorbid health. In particular, those who are blind and visually impaired are a lot more increased of falls and mechanical injuries. And those who are blind and visually impaired also have a lower mortality, a lower life expectancy. than the normal population. So really severe consequences of being blind and visually impaired, which is kind of central to some of these concepts that I'll go into. So before we go on, we'll just talk about some definitions of visual acuity, of blindness, of visual impairment. The WHO definition of blindness is as such, and I used to think that blindness was just completely being able not to see and being like blacked out vision. Not necessarily like that. Visual acuity is a vision that is worse than 360. Now, to explain that visual acuity score, visual acuity is how well you see, basically. It's how sharp your vision is. 360, when it's written like that, means is how your vision will be measured by Snellen chart. Snellen chart is that chart that's very common in opticians and ophthalmology clinics, where it's a white background and letters on it. The letters get smaller as you come down the chart, and that's how they will measure your visual acuity. Visual acuity of 360 means that an individual with that visual acuity from 3 meters can see what a normal person can see from 60 meters. If you take that patient further away from the object than 3 meters, they can't see that object anymore. So you can see how severe that kind of vision is. So that is blindness. And the WHO definition of visual impairment is a visual acuity anywhere between 360 and 360. So once again, just to explain the concepts, and hopefully you're able to understand, a visual acuity of 360 means that an individual from 3 meters can see what a normal person can see from 16 meters. If you take the person further more than 3 meters away from the objects, they can't see it anymore. So that is the definition of visual impairment. And these definitions are with the caveat that these are for the best seeing eye and with appropriate refractive correction for the patient or individual as well. So glasses or contact lenses is refractive correction. And what's the definition of global health? Global health is the health of populations in a global context. It has been defined as the area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. So that's a really important concept again, as we'll go on to discuss the importance of global health ophthalmology in this presentation. So why is global health linked with ophthalmology? Why are they so intrinsically important to one another? So in terms of answering this question, I thought I'll pose to you some statistics. I've put the number out, I've blanked it out, and I will ask you to guess the number with some of those options that we have at the bottom. I've got a number of statistics. We'll go through them. I'll tell you the answer, and then we'll discuss why they're so important. So to start with, blank percentage of visually impaired people live in low and middle income countries. 89%, 79%, 69%, or 59%. So just have a think about that. I'll give you a few seconds to think of what your answer would be. And so the answer for this is 89%, massive proportion of visually impaired people live in low and middle income countries. Blindness rates in high income countries are generally below 0.5%. In low income countries, blindness rates may exceed blank percentage: A, 1%, B, 2%, C, 4%, or D, 6%. So once again, just have a little think about that and think of what your answer could be. And the answer for this is 2%. Blindness rates in low-income countries may exceed 2%. And again, you're already starting to see the idea of the disparity that is really evident in global blindness. Blank percentage of adults under 50 are blind in sub-Saharan Africa versus 0.4% in high-income countries. Is it 3%, 6%, 9%, or 12%? So have a think about that. So the answer for this one is 6% of adults under 50 are blind in sub-Saharan Africa. Another example of the disparity. Blank percentage of the 39 million blind people in the world are women. So is it 50%, 57%, 60%, or 64%? So the answer for this one is 64%. Mind-blowing statistic. A massive proportion of the million blind people are disproportionately women and not men. So many low-income countries have a childhood blindness rate of around 1.5 per 1,000. High-income countries generally have a childhood blindness rate of blank per 1,000. 0.1, 0.3, 0.7, or 1.2. So the answer for this one is 0.3. High-income countries generally have a childhood blindness rate of 0.3 per 1,000 people, a lot lower than low-income countries and childhood blindness. Finally, maybe the most important statistic to truly understand global health ophthalmology, why we intervene in global health ophthalmology, is this statistic. By most estimates, up to blank percentage of global visual impairment and blindness is reversible. 30%, 50%, 66%, or 80%. So the answer for this one is 80%. A massive amount of the global visual impairment and blindness is classed as reversible. And as we go on, we'll think about what reversible actually means and why we target these conditions as global health interventions. So what those statistics have shown is that there's a massive global disparity that's evident in global blindness and visual impairment. It's disproportionately affecting those low-income countries is one of the main things that we've got from those statistics. And why is that? The conditions are multiple and ongoing. I can only summarize and scratch the surface of why that is. Lack of trained ophthalmologists in these countries, poor nutrition in some of these countries, of which is a risk factor of developing disease. A high proportion of low-income countries are in areas that have high UV radiation. That in itself is a risk factor for developing some diseases that cause blindness and visual impairment. And also in some of these countries or areas, the demographics of it is such that there can be poor practical access to treatment centres, more rural communities, less access as in infrastructure access for them to get to urban areas where the treatment centres might be, and or economical access to treatment centres, which may cost money to see an optician or see the ophthalmologist, and that may be a barrier for people to prevent treatment, which may later on progress to blindness or full visual impairment. And another interesting concept in global health ophthalmology is how it relates to global development. It's intrinsically linked. It goes beyond medicine. The consequences of blindness are already more significant for low-income individuals or those in low-income societies. So the effects that they cause, that we talked about before, are going to hit them harder. And also, global blindness and visual impairment can cause poverty. Again, linked to some of those other effects of blindness that we looked at. And then poverty is then linked to global blindness and visual impairment, as we looked at some of the why there's such a disparity between low-income countries and their higher rates of global blindness and visual impairment. So it's like a never-ending cycle of this massive macroscopic aspects of how global blindness and visual impairment is affecting global socioeconomic development of communities, of nations, of populations. So if we try and intervene with global health ophthalmology and try and target global blindness and visual impairment, you may well have a massive hand in helping poverty, helping bring people out of poverty, providing more opportunities for them, providing, in essence, and in very general terms, socioeconomic development for an individual, for a population, for a country. So really, really massive potential for benefit with these interventions in global health ophthalmology. So now we'll just look at some of the causes of global blindness and visual impairment. And again, I'd like to think about what diseases are major causes of global blindness and visual impairment. So again, I'll give you 10, 15 seconds just to have a quick think about what some of these diseases might be. So I should have warned you that I was about to click off the slide there, but hopefully you did think of some of the answers to that, and they might be on this slide right now. These are the leading causes of global blindness and visual impairment worldwide. There's 7 causes. I've split them between conditions that traditionally have been affecting high-income countries more, or associated more with high-income countries, and conditions that traditionally, and certainly contemporarily as well, are affecting low-income countries more than high-income countries. So with high-income countries, I've highlighted cataracts, age-related macular degeneration, glaucoma, and diabetic retinopathy. As you may know, that of course is linked with high-income countries generally have a demographic of an aging population. These are conditions that can all be related to age, chronic diseases of age, and that type of thing. Uncorrected refractive error, cataracts, glaucoma, corneal opacity, and trachoma are all linked with low-income countries more than they are high-income countries. Other than in cataracts and glaucoma, as you can see, that there are issues in both countries. In both types of countries, and the reasons why they are as prevalent as they are is different. The context is a bit different for why cataracts is so high in high-income countries as compared to low-income countries. The same with glaucoma, but they are truly global barriers in global blindness and visual impairment. So now, if we just focus on the right-hand column, low-income countries that have these causes of massive blindness and visual impairment, and we shall think about them in reversible disease and preventable disease. I find it useful to class them into this group and think about, or it'll help us think about why they're also so important in global health ophthalmology. So easily reversible causes in this case is uncorrected refractive error and cataracts. Uncorrected refractive error, I've classed that as reversible because uncorrected refractive error simply means your eye is refracting light either too much or not enough. Your cornea is refracting light too much, or your eyeball's the wrong shape. Very common. I have a refractive error, and that's why I'm wearing glasses. So glasses is how you correct refractive error, or contact lenses. It will change the refraction. It will mean that you see better at a better visual acuity. If I take my glasses off, my visual acuity without glasses is 322, roughly. So 322 means that from 3 meters, just to reiterate, from 3 meters, I can see what a normal person sees at 22 meters. That means that by the WHO definition of visual impairment, I, without glasses, would be visually impaired. So think about all the people that wear glasses and contact lenses that you may know. They would all be visually impaired without it. Certainly in the UK and maybe other high-income countries, it's just something that you don't even think about, wearing glasses or contact lenses and what life would be like without it. But unfortunately, as you can see, it's a global blindness it's a cause of global blindness and visual impairment. So it's a really easily reversible cause despite that. Cataracts as well, I've classed as an easily reversible cause because you do need surgery to fix cataracts, but actually cataract surgery is quite well known for being efficient. It's very cheap surgery to do. The benefits that you get from the cataract surgery has a really well-known public health model of increasing, of basically being economically efficient, because the person has their sight regained through the surgery, and they're able to not have falls. They're able to get back to work, and things like that. And also, it's a relatively easy surgery for an ophthalmologist to carry out. So again, really reversible causes, and yet they are some of the leading causes of global blindness and visual impairment linked with low-income countries. And if we look at preventable causes, these are corneal opacities and trachoma. And we'll go into some of these diseases in more detail in a later series of this webinar, but these easily preventable causes I've classed as such because some of the things that prevent them can be a good and healthy balanced diet, good hand hygiene, and insecticides. So that's why you don't really see too much corneal opacity, and you certainly don't see trachoma in high-income countries, but they are associated and endemic to many other countries worldwide. So with this concept of preventable disease and reversible disease, you can start to build a picture of avoidable blindness. Blindness that is quite easy to or should be theoretically easy to intervene and prevent and or treat. And yet there's a massive proportion of blindness worldwide that is avoidable. So really important concepts in global health ophthalmology: avoidable blindness. Here's this definition from the International Agency for Prevention of Blindness. It is defined as blindness which could be either treated or prevented by known cost-effective means. Although there are many other causes of vision impairment, IAPB seeks to address the main causes of avoidable blindness in order to have the greatest possible impact on vision loss worldwide. So you can see just avoidable blindness is just a major target for global health ophthalmology. And it makes sense, doesn't it, to target those easily preventable or easily treatable conditions. We'll briefly touch on global health interventions. There are many interventions out there to combat avoidable blindness and support global health ophthalmology. From local charities to large non-governmental organizations to the World Health Organization itself, which is involved in an initiative called Vision 2020. This was formed in 1999 by WHO and IAPB, as previously mentioned, with a goal to eliminate global blindness by 2020. So this is an important case study in the concept of global health ophthalmology. I'm not going to go into it anymore for this particular series, but really interesting to read through the kind of things that movement instigated, some of the successes they have and some of the challenges that they've had as well since 1999. So that's Vision 2020. And that is for next time. So that is the end of part one. So thank you for listening. I hope you've enjoyed this quick introduction to global health ophthalmology. So please keep a lookout for part two. In part two, we'll focus on 3 avoidable causes of global blindness and visual impairment. Keep an eye out, like and subscribe to the Medics.Academy YouTube channel, where some of my colleagues as well that I met on the virtual elective will be posting their videos too. Thank you for listening. I hope you've enjoyed it, and have a good day. Cheers.
Well, it's time to learn about causes of global blindness in Josh's next video.
Hello, guys. My name is Josh. I am a final year medical student at the University of Southampton, and this is part 2 of my Introduction to Global Health Ophthalmology webinar, which I've done with the kind help of the Medics.Academy. I did the Medics.Academy virtual elective program in May, and this has culminated in doing this series of webinars. So I did part 1. Part 1 was basically an introduction to the whole concept of global health ophthalmology, why it's so important, why ophthalmology and global health are linked. And in part 2, we shall discuss this. We shall discuss 3 avoidable, preventable causes of global blindness. We'll look into these 3 causes in a bit more detail. For those of you that live in the UK or maybe other high-income countries, these are conditions that you may not have come across before, but they are important to kind of know about in a general sense, not for medical school exams, but more just for general knowledge. I think they're really massive diseases, and yeah, I think we'll just crack on and get straight into it. So an introduction to me: I am as I said, final year medical student, University of Southampton. I have an interest in ophthalmology, medical education, and research. And I guess my interest in ophthalmology and medical education is why I'm doing this series, and why this topic, I'm interested in it, and why this topic of global health ophthalmology, I should say, I'm interested in it. It's kind of interesting, I think, from a general knowledge perspective, because it's not necessarily on medical school curriculums, but an important topic to know about in a general sense, get an understanding of or feel for global health, and just good knowledge really about socioeconomic development, and about global health really. So, and I put the asterisk there as well for those who haven't seen from the first video. Although this stuff isn't in medical school curriculum, if any of their students watching who are interested in doing a Duke Elder exam, this stuff is important for that exam. If you're not sure what the Duke Elder exam is, I gave a very brief introduction in part 1, but do look into it if you're interested in ophthalmology and you're a medical student in the UK. Cool, so we'll just get on with the presentation now. So in part 1, I introduced this towards the end: avoidable blindness, preventable disease, and reversible disease. In this part 2, we're going to be looking at preventable diseases. We're going to be looking at the diseases that cause corneal opacity. And we're also going to be looking at trachoma as well. So all these diseases, they're not necessarily common in places like the UK, but they are common to other countries worldwide, and we will go through them in a bit more detail. So we'll start with onchocerciasis, or river blindness. What is onchocerciasis? It's a parasitic disease. The causative agent is Onchocerca volvulus, which is a parasite, and the vector is a female black fly, which it spreads the parasite by biting other humans. The parasite then comes into the tissue or bloodstream, but certainly once the parasite's inside the body, it lays multiple offsprings, and they travel in the bloodstream to where they're going to cause lots of issues, but we're going to be focusing on the eyes today. So epidemiology, 21 million people are infected worldwide, but 100 million people are classed as at risk of the disease. It's relatively common in 30 to 40 countries, so quite a lot of countries do have this problem. And it's those who live or work near bodies of water who are most at risk, which is where the black fly breeds. In this image, it's just showing areas where onchocerciasis is still endemic. The more red the country, the higher the prevalence of onchocerciasis. You can see that it's affecting sub-Saharan Africa, in particular Nigeria, also affecting some of the northern countries in South America. It's affecting Mexico as well. It's affecting Yemen. So quite widespread, and of course not something that we're seeing in the UK, however. In this image, we'll look at the image on the left first. So that's a zoomed in image of a female black fly. Coming out of its antenna on the left, that is actually Onchocerca volvulus itself. That's the parasite coming out. Quite gruesome, quite interesting, depending on how you look at it. But so that's it there. I've put the ruler here because this parasite kind of grows to be 50 to 80 centimeters long. So mind blowing to think about it being in a human body, but that is the anatomy of it. And I've put the calendar because this parasite can, once infected in a human, it can stay there for up to 14 years, a really chronic infection. And you can imagine that when you've got this thing inside you for 14 years, the damage it can cause if it gets to your eye. In these images, on the left image, that's showing the actual parasite itself again, and it's in the anterior chamber of someone's eye. It's swimming around, it's live, it's mobile. It would be mobile if the image was playing, and it's just in front of the pupil. And you can imagine having something like that in your eye is going to cause problems, and we'll go on to the pathology in a bit. On the right, there's this pathognomic appearance that you get, mainly on the shins, I believe, of this raised lump, and it's called an onchocerca martyr. Onchocerca martyr is another place where the parasite can go, and it will basically, I believe that the multiple larvae that have originally come from the first infection will culminate in areas like this in the onchocerca martyr. So yeah, so just two signs to know about. So what's the pathology of onchocerciasis? So basically, as we just saw in the previous image, the parasite comes into the eye, and actually preferentially will come to the eye. Like with the onchocerca martyr, it's mainly associated with coming into the eye. Once it comes into the eye, the parasite likes to burrow into the cornea. And once it does that, it just causes, as you can imagine, it damages the cornea, and it causes lots of scarring. As more and more parasitic larvae come into the cornea and burrow in, it eventually causes corneal opacity. The cornea is damaged, it loses its transparency, and you may end up with an eye like this. Totally not be, they will not be able to see like this, and very serious once the blindness gets to this level of corneal opacity. I'll talk about why corneal opacity blindness is so severe, but as you can imagine, really affecting vision there. So how do we prevent and treat it? Why is it easily preventable? Well, we can prevent with insecticides, and we can prevent and treat with ivermectin. Insecticides, of course, are targeting the female black fly vector, and prevention and treatment is with this antiparasitic drug called ivermectin. And as I understand, it's completely revolutionized the treatment of onchocerciasis in many populations all over the world. And when I think of ivermectin, it's amazing. I think if you wanted to design a drug that could combat onchocerciasis in some of these communities, you would probably design it as ivermectin. Why? Because it's effective. It just works very well in combating onchocerciasis. It's cheap. It doesn't need refrigerating. It only needs to be taken at one dose once a year to provide prevention or to treat a patient who might have parasite. So really important role it's had. And of course, these are just the two mainstays that global health strategies or interventions will involve. They will go to endemic areas where the population is known to be at risk or have circulating onchocerciasis. They will treat everyone within, well, first they will incorporate lots of insecticides, but also importantly, they will treat everyone with ivermectin, as many people as they can. And they'll go back again every 6 months or every year, and they will treat everyone again. They'll do this for 14 years. And at that point, you should know that in that community, everyone has been treated for onchocerciasis. But as I understand, most countries will do this for 6 to 8 years, so still several years. And by that point, it tends to be effectively eradicated in communities. So that is onchocerciasis. So for the next condition I'll talk about, xerophthalmia is the name of this condition, and it is a subset of vitamin A deficiency. So we'll go into this now. So first, we'll define vitamin A. What is it? It's important for retinal pigment formation, and that's why your parents always tell you to eat your carrots, which vitamin A is known to have, and you'll be able to see in the dark. But it's also important for cell maturation, division. It's an antioxidant as well. It's found in carrots, stock, green leafy veg, liver, fish, egg, and dairy as well. In vitamin A deficiency, that in itself is a really important kind of topic and concept in global health as a whole, not just in ophthalmology. It correlates with poverty, with comorbidity and mortality. Sorry, not morality, mortality. Why? Why is this such a issue in some countries? Some countries just have less access to animal products, less access to supplements, and also the type of populations that will be affected by vitamin A deficiency are also the type of populations that may have, unfortunately, may be associated with lots of chronic diarrhea. And that type of chronic diarrhea means the less absorption of vitamin A. So again, chronic diarrhea is another massive global health issue. So it's all kind of culminating with vitamin A deficiency. But we're looking at xerophthalmia here, the ocular manifestation of vitamin A deficiency that may progress to blindness. Here is a map again of how xerophthalmia is spread throughout the world. You can see in red, those are areas where it's classed as clinical. In orange, severely subclinical, and in yellow, moderately subclinical. You can see the areas where it's clinical are including lots of sub-Saharan African countries, Yemen, some of the South Asian countries, some countries in Southeast Asia as well. So really big spread. And this is the progression, the pathology of xerophthalmia. And it does actually start with night blindness, the thing that your parents were telling you to eat your carrots for. But then it's actually a spectrum of disease, and it does start to get more and more serious. After the night blindness comes a dysfunction of tear film production. Once you've started to affect tear film production, you're going to start seeing effects on the conjunctiva and the cornea, which need that tear film to have normal function. You might get crystallization of the conjunctiva, known as Betos spots or conjunctival cirrhosis, which this image is showing here. It's in the equator of the eye, so those are Betos spots. And after that, you might get an even more severe effects, the diffuse drying out of the cornea, corneal cirrhosis. And as those of you who will have had ophthalmology placements or are going to have ophthalmology placements, you'll find out that once you dry the cornea out, you're removing one of its main protective factors. You're going to make it very vulnerable to infection, ulcer, and perforations as well. And that's exactly the case here. At the kind of end stage of xerophthalmia is a corneal ulcer perforation. And that is when the cornea is starting to get affected, and it's really going to affect your vision permanently. How do you prevent geophthalmia? As many of you may have guessed, it's through vitamin A supplementation. It's as simple as that. It's a major target for global health intervention. Again, it's not just ophthalmology we're talking about here. Vitamin A deficiency has very widespreading consequences and effects. So again, this is looking at the fact that we're reducing blindness with vitamin A supplementation, but we're also reducing mortality as well. And finally, the last disease that we're going to look at is trachoma. What is trachoma? It is a disease that's caused by repeated conjunctival infection by Chlamydia trachomatis serotypes A to C. So these serotypes are not the STI version of Chlamydia trachomatis. That's serotypes D to K. This is A to C that's causing the disease trachoma. It's the most common global cause of infective blindness. Epidemiology, so risk factors for trachoma is poor hand and face hygiene, being close to others who are infected, being close to lots of people who are infected, and being in close proximity to flies as well. In some respects, it's a bit similar to the concepts or the epidemiology factors with onchocerciasis, because you get these endemic communities where everyone might be infected, they're spreading it to each other, and of course, again, they're native vectors for flies. So it is also endemic to 51 countries as well. So again, quite widespread, but not something that you necessarily see in the UK. This map again is showing prevalence of trachoma worldwide. You can see it's mainly affecting sub-Saharan Africa and North Africa as well, and some other countries dotted around the world. So lots of countries it's affected, but again, not maybe the high-income countries or the traditionally high-income countries. So what is the pathology of trachoma? The repeated infection of Chlamydia trachomatis, it will cause scarring of the conjunctiva and changes to the conjunctiva and the eyelid that's as well. On the left, you can see this condition or effects of trachoma, which is called trichiasis. It's the interning of the eyelashes. On the right, what I've tried to show is entropion, another change associated with trachoma. It's the interning of the eyelid. What this image shows as well, if you look carefully, is that both the trichiasis and both the trichiasis combined with the entropion is causing the eyelash to scratch against the cornea. Once you've got those changes, the eyelash is going to continually scratch against the cornea, and that's going to affect, again, it's going to be affecting and damaging the cornea. And once you start to affect and damage the cornea, it's going to affect transparency of the cornea. Once it starts to scar up, and that's going to really affect sight. So yeah, as I mentioned, just again, repeated infection leads to trichiasis and entropion, which leads to corneal damage. So we prevent and treat trachoma with this SAFE strategy. That's how global health interventions it's what they revolve around. So in terms of treatment, it's surgery or antibiotics. Surgery is the main treatment for any eyelid deformity. In this case, it's entropion. And antibiotics, a single dose of azithromycin can eradicate the infection. But more importantly, in this case, is still the prevention, because it is so simple, and it's good hand hygiene, good face hygiene, and environmental change, good education within the population to know about how serious this disease is, and that they may unfortunately be carrying it, and to make sure that they are or at risk of it as well. So they may just have to observe that good hand hygiene and face washing. And so in summary, what have we looked at? We've looked at 3 diseases that are easily preventable. They're easily treatable in the early stages. But left untreated, they can progress to serious corneal damage. We've seen with all 3 that when they're not treated, they're not prevented, they progress to corneal damage, corneal opacity. Once you've got to that stage of sight loss, or once you've got to corneal opacity, the only way to treat it, even if you get rid of the infection or you get rid of the parasite or you give them vitamin A, the only treatment for that loss of opacity in the cornea is a corneal transplant. And that's something that's really for want of a better word, quite a big surgery. It's quite a high-end surgery, and it's something that ophthalmologists have to train years to really get a hold of. So yeah, you can really see why it's so important to prevent these diseases. And yeah, that last bullet point is just to really reiterate that point. These are 3 easily preventable diseases, and yet they're still some of the leading causes of global blindness and visual impairment. Please look back at part 1 if you want to see other causes of global blindness and visual impairment. So that is that. And then again, just to reiterate, this is what we've looked at. We've looked at some of the preventable diseases that are part of avoidable blindness. So that's why global health interventions look at these diseases to try and combat the disparity in global health, blindness, and avoidable blindness. So that is the end of part 2. We've looked at 3 avoidable causes of global blindness and visual impairment. I will end it. So I'll end the presentation here, and please keep a lookout for part 3. In part 3, we'll be looking at a case study of a global health intervention. So keep your eye out for that on the Medics.Academy YouTube channel. Please like and subscribe this video. Hope you've enjoyed it. I hope it's been good information for you. So have a good day, and see you in the next video.
First session, Josh will be interviewing the program director for an amazing organization called Selfless UK.
Hi guys, my name is Josh. I'm a final year medical student at the University of Southampton. This is part 3 of my series of an introduction to global health ophthalmology. So I did this series as part of the Medics.Academy virtual elective. I did the virtual elective in May, and this has been the culmination of all the work that I've done, and also the program I've done to help me with it. So if you've missed part 1 and part 2, please do check it out on the Medics.Academy YouTube channel. In part 1, I have talked about kind of just really introducing the whole concept of global health ophthalmology, why it's so important, what are some of the causes, and information such as that. In part 2, I've covered 3 avoidable causes, and in particular, they're all preventable causes of global blindness and visual impairment. So there's some really interesting stuff there, hopefully. And finally, in this presentation, I will be looking at a case study of global health ophthalmology with a charity called Selfless UK. So that's what this presentation will be about. So thanks for joining, and we'll get straight into it. And as an introduction, who am I? I'm a final year medical student at the University of Southampton. I have an interest in ophthalmology, medical education, and research. And I guess that interest in ophthalmology and medical education is why I'm doing these videos, or why I've chosen this series. Why have I chosen this topic? I think it's interesting, not normally on the medical school curriculum, but global health ophthalmology is an important topic to know about just for general knowledge. I think it's interesting in terms of how it's working with global socio-economic development, and similar ideas such as that. And for those who are watching who are interested in taking the Duke Elder exam, the stuff that I've gone through in part 1 and part 2 and a bit of part 3 as well is important for the Duke Elder exam. If you don't know what the Duke Elder exam is, do see my previous videos, and I talk about it in the introduction sections for those videos. But basically, it's just an exam that medical students in the UK can do who are interested in ophthalmology and want to get basically just points on their interview, for their CV and for interview points for specialty. Okay, so in this case study, we'll look at the charity Selfless UK. It's a UK charity aiming to improve healthcare equity in Bangladesh. It does various projects focusing on different disease interventions, including ophthalmology, but not limited to ophthalmology. They also do many other things, as you'll see in the video. And also, it's a really good case study because it provides opportunities in global health, volunteering, leadership programs for medical students. I think a lot of this audience may be medical students watching this video, and that's why I think this case study is just great to bring in, because it's looking at global health, it's looking at ophthalmology, and it's got that opportunity for medical students who may want to get involved in this topic. It gives an avenue for them to get involved in more. So The interview, I interviewed Dr. Jingi Alam, he kindly agreed to just give a quick interview a couple of weeks ago with me, and I recorded it. He's an F2 doctor and program director at Selfless UK. In the video, he's going to discuss how he got into the program, his successes, his challenges, and how students can get involved as well with Selfless UK. So I will come out this PowerPoint now and just quickly come to the video itself.
Hi, Jingi. So thanks for joining me today and helping me with my presentation on an introduction to global health ophthalmology. I'm just hoping to have basically a presentation on you and the work that you're doing in global health ophthalmology, and for it to, with our audience being medical students for the webinar. So that's how it's going to go. So first, I'm just going to ask you, just do you want to introduce yourself and kind of what you're doing at the moment?
So cheers, Josh, for bringing me into your elective program. So my name is Jingi. I'm an FY2 doctor in Leicester. I graduated from the University of Southampton in 2018. I first got involved with the charity Selfless UK in 2015 when I went as a volunteer on their elective aid program for 4 weeks in and around various parts of Bangladesh, and then continued to stay involved with the organisation. And now I'm the program director at Selfless, where I run the Global Health Leadership Program aimed at junior doctors and medical students. And I'm also the founder of Porishkar, which is the cataract surgery service that we run in rural Bangladesh. So I've been doing that for about 5 years on and off. But in the most recent year or so, I've taken over the organisation from our founder, Naeem Ahmed.
Okay, so that's some really great stuff that you're doing. And could I ask you, like, what was it that first interested you about these like programs in global health ophthalmology?
So I myself come from a Bangladeshi background. My family are from Bangladesh. I was born in the UK. So, I was always mindful of my identity, how British was I, how Bangladeshi was I. So I always wanted to get involved with some work in Bangladesh. And then this opportunity came up on LinkedIn in 2015. And a friend of mine, a non-medic friend of mine from Southampton, went on to work for Selfless. So she approached me on LinkedIn being like, do you want to come along? So I didn't really know much about the organization or what they did. And I went along, and I think it was the perfect time for me because I was hitting a bit of a dip during my, I think I was at university for 3 or 4 years at the time. And I just, was getting a bit burnt out by the whole thing. And then it really energized me going to Bangladesh, seeing what the healthcare system was like, how Selfless UK operate in Bangladesh really excited me. So I came back and I got in touch with the founder and asked him how I can continue to get more involved and stay involved. And so slowly I took on a bit more responsibility every year. And actually about March, April time in 2019, I met up for a coffee with our founder and approached him about this ophthalmology project that I had in mind. And it all started from there, really. And then the Global Health Leadership Program was just an evolution of the elective aid program that we were running for years. So, the organization has been going on since 2008. And so I didn't really intend to be in the position I'm in now, but it was really just how one thing led to another, really.
Yeah. Oh, it's good how things end out there and the ways that's happened for you. And could you talk a bit more about like some of the aims that Selfless has as an organisation and as a charity?
I think essentially it boils down to universal healthcare. And at the moment we run three big projects. So we run Porishkar, which is a ophthalmology, a cataract surgery service that enables people who have lost their jobs due to their cataract and fixes that problem by giving them free cataract surgery and helping them then get back into work. So ultimately avoiding poverty, avoiding joblessness, and empowering them to go back into work. So that's the project that I focus on mainly. We set it up last summer, and it's really picked up since. And then we've got the dental hygiene project that we run with Tanvir Kamali, who's a final year dental student at King's. He leads this dental hygiene project, which is basically public health information, how to brush your teeth, why it's important to brush your teeth, giving young people in primary schools a toothbrush to use at home, a bamboo toothbrush to use at home. And then we run Upahar, which is a antenatal program. So we sign up women in rural villages to our antenatal program. And if they complete the program, then they get a baby bundle, which is a bounty pack with all the essentials for the first 8 days of life. Trying to make every young baby in Bangladesh have an equal start to life. So those are the programs that we run throughout the year. And then every year when we take our delegates out to Bangladesh, we run huge health camps, which are like GP services in villages that don't usually have any access to healthcare, which is quite an exciting and exhausting project. But we find that our delegates find it really beneficial to be in that environment.
Yeah, that's all really good. I can see that you're in like not just the aspects of ophthalmology and global health, and in that aspect you're targeting cataracts, which is such an important aspect of it. But you're also looking at different global health aspects. Yeah, so even I didn't know that. So I didn't know that you're doing pregnancy. Obs and gynae global health, which is important as well, and even dental. So that's kind of outside of medicine. So that's all really good stuff you're doing.
So the thing is, we do within the organisation. Once our delegates finish the Global Health Leadership Programme, we encourage them to think of their own projects, their own global health programs that they want to introduce. So use it as a sort of launch pad for various, because we have the infrastructure in Bangladesh. We have our Bangladesh team out there who are, I think one of the questions that comes up quite often is, what are the obstacles that you face? And it's the cultural barrier. But given that I come from a British Bangladeshi heritage and work in Bangladesh, there is some common ground and we are able to communicate quite well. So we have that opportunity to do projects that our volunteers or our delegates or sort of graduates from our course come up with, which is quite unique to our organisation.
Oh, that's good. And you've actually answered one of my questions that I was going to go on to, because I was going to ask you what your obstacles were, but that barrier that you mentioned, of course, being one of them.
Yeah. I think another barrier that I should mention, which is really important when it comes to global health work, is making sure that these projects are sustainable. A lot of the time when you run these projects, you rely on donations from friends and family, you rely on donations from the public. And so at the moment, we're exploring other ways of funding our projects, which, inevitably in any charitable organization will be something at the back of your mind all the time.
Yeah, that's an important point as well. Definitely, I can see that. But now we've got the barriers out of the way. That means we can focus on any successes that you've had, either just as the organisation as a whole, or the projects that you said you've been particularly involved in with the cataracts. What do you think's been the best success or highlight so far?
I think some of the successes we could talk about are, having people from a diverse range of backgrounds coming onto our program and experience the Bangladeshi healthcare system, being able to give them that insight into healthcare in Bangladesh, into the health beliefs of Bangladeshi people. A lot of these guys come back and work in the UK, and might serve a population of British Bangladeshi people, and be able to click with those patients, be able to think differently now that they've been on our program, be a bit more open to these cultural beliefs that people have from Bangladesh. That's a success in terms of what our volunteers gain. And I think, the organisation has been running for 12 years now, so that itself is a success. Being able, when we run our health camps, we reach out to thousands of people per year, more than 3,000 each year. Our programs, our ophthalmology program has put, I think up to this date, we've put about 50 people back into work.
That's great.
We've intervened on their cataract, the consequences of their cataract, and helped them, empowered them to get back into work. And I think that's what's important to me. It's not turning up and doing a project and then leaving. For me, it's about empowering the local people and helping them take control of their health and their own life. That's why the Eye Project is very important to me.
No, that's really good. That's such good impacts that you've been able to have so far. So we're just running a bit out of time, and is it all right if you could mention how medical students are able to get involved in the organisation as you yourself have?
Absolutely. So every year we run a global health leadership program. Recruitment for that opportunity starts in September. So everyone puts in an application, has a Skype interview. We take on healthcare students and professionals from any background in any healthcare profession, and then so that they can get involved through that stream of our work. And we usually go to Bangladesh in July every year. This year we're gonna run 2 programs, one in March, springtime, and one in the summertime. But when I say this year, I mean 2020 to 2021. But given everything that's happened with the global pandemic, all of our programs this year have been postponed. So, we were supposed to go to Bangladesh July the 10th this year, but that got cancelled. But, medical students can get involved by applying for our Global Health Leadership Program. We're working in partnership with the Healthcare Leadership Academy and Medics.Academy to introduce a global health element to the work that they do. So I think the best way at the moment would be to sign up for our Global Health Leadership program, which can be found on our website, which is www.selfless.org.uk.
Cool. Yeah. And I hope that provides an example of how medical students can get involved in global health to the audience of this. So I think we covered everything that we could cover in this short time. There's loads more I wish I could have asked you, but it's been a really good interview. So thank you for joining me.
Cheers, Josh. Thanks for having me.
It's all right.
Nice one, Josh. Take care.
Yeah, you too. Cheers.
All right, so that was that video. I hope you found it interesting. We'll go back to the PowerPoint. So yeah, I hope you found that interesting. It was really good to speak to Jingy, speak to him about what he's done with Selfless UK. Really, really great examples of some of the things that we covered in part 1 and part 2 of these series, in particular, the cataracts and implementing the cataract surgery program and the effects that it's had on the patients who have used the service. Really far-riding impacts that treating global blindness and visual impairment can have. So really great thing he's doing. And thanks again, Jingy, if you're watching, for helping me with that interview. So,
hi, Jingy. So thanks for joining me today. And
so more info on Selfless UK. That's their charity there, www.selfless.org.uk. Instagram and Twitter @SelflessUK. If you're at all interested in getting involved email Jingy if you have any further questions. So that's his email up there that he's happy for me to send out for any medical students who are interested. And also just to say, the next round of the Global Healthcare Leadership Program that Southwest UK are running, this is for the summer 2021 expedition. The application period is opening soon. It's opening in September 2020. So if you are interested, and you should be interested because it's such a great way to get involved with leadership, global health, really great thing to just do, and so many great experiences that you'll see. Do keep an eye out for it. That'll be opening in September 2020. So yeah. So that is the end of part 3, and also the end of this series of videos about an introduction to global health ophthalmology. In a summary, I hope that watching this series will help answer the questions. I hope these are the kind of aims that I wanted to get across in the videos. If they haven't come across well, then it's probably my fault, because this is what I wanted you to be able to answer. 1, why is ophthalmology so important in global health? 2, can you name and briefly describe 3 easily preventable diseases that cause blindness? 3, name some case studies or initiatives that aim to tackle global blindness and vision impairment. And 4, if you are interested, how can you get involved further in global health ophthalmology? And thank you so much to the whole Medics.Academy team, to Johan, Anna, Hibba, Jack, Dr. Alan, also to Eamon, who's helping out with the videos as well. And also thank you to the Medics.Academy May elective cohort. So the other guys who did the program with me, really good to meet you all. I'm really looking forward to seeing your videos. So thanks for all the help that you guys have all given me in some of the ideas that I've had, and this presentation itself, and the other things that I've done with the virtual elective. So thank you guys. So thank you. Thanks for listening. I hope it's been informative. I hope that this series of an introduction to global health ophthalmology has been good for your learning and your general interest. If you have any questions or you want to get involved with the virtual elective itself, please direct them to the Medics.Academy team. They're on Twitter, they're on Facebook. Just a simple search that they'll come up. They'll be top. And I am also on Twitter, so I'm at Joshua Adeju with an underscore at the end. If you want to ask me any questions as well about the virtual elective or about the presentation that I've just given. I'm also on LinkedIn as well, so if you want to connect, if you're also interested in ophthalmology, medical education, research, anything like that, then do connect with me on LinkedIn. And finally, do like and subscribe to the Medics.Academy YouTube channel. That's where all these videos will be posted. If you haven't seen part 1 and part 2, do go check them out, and I hope that it's been good. Also, my colleagues, as I said, my colleagues that I've met with the virtual elective experience, they will be posting their own videos on all the different really interesting topics that they decided to do theirs on. So keep an eye out. It's been really good experience. I hope this video has been good. And thank you for listening. Have a good day.
Thanks so much, Mario and Josh. Those are some really great teaching sessions. Remember to join our Slack page, join our S.Dot Facebook page, as well as like and subscribe to the Medics.Academy YouTube channel to get notified about our next exciting episode.